Quickly, I'll show one video technique of inside-out repair of a complex ramp region. It's a type 5 ramp. So coming to the case history, it was a 20-year female. Here was a 20-year female with history of twist injury 4 months back, presented with pain and instability of the left knee. On examination was found to have joint line tenderness, full range of movement, Latchman and pivot shift positive. McMurray's test was positive and no mediolateral instability. The MRI showed complete tear of the ACL with the meniscal irregularity on the posterior part of the medial meniscus. And on diagnostic scopy, here was a complete tear of ACL. The lateral meniscus was good. The medial meniscus was looking good, but when we entered into the posteromedial compartment through Gilchrist portal, there was a big ramp lesion which is extending anteriorly. So we did pie crusting to see the entire morphology of the posterior part of the meniscus, whether it is intact or not. So we went ahead and with the help of a needle or this rod, we examined the ramp, and the ramp was extending too anteriorly. Then from the anterior side, it was with the help of a probe, we saw that it was a double tear. So it was a kind of type 5 ramp lesion. So we decided to deal it with inside-out repair. We debrided this meniscus from the fibrous tissue with the help of a saver, and with the help of a rasp from the anterior side on the superior surface and the inferior surface, the rasping was done, and trephination was done to stimulate the healing with the help of a small spinal needle. And once it was done, then inside-out repair was tried with the help of a zone navigator. After giving a posteromedial safety incision, we went for sub-semimembranous approach to retrieve the needle. So first, with the help of a zone navigator, keeping the zone navigator outward, first the medial most suture was taken, and then the needle was passed through the zone navigator, and the needle was retrieved through the posteromedial safety incision. The first needle, you have to be very careful to retrieve both the needles from the first suture, and it should be under vision, and the suture tape was used for this. Then the second suture was retrieved by taking bites both on the peripheral capsular area and from the center part of the meniscus. And after taking 2 bites, then on the inferior surface, we took the bite from both the parts of the meniscus and the meniscocapsular junction. So once you take these 3 bites, then the meniscus is stabilized. Then you come anteriorly and give stitches to the other rest of the part of the meniscus, and you have to incorporate the middle fragment to the posterior meniscocapsular area and to the anterior part of the meniscus by giving stitches alternatively anteriorly and posteriorly. And once you do that and take sufficient stitches and check the stability, then you come again to the medial most part or the posterior most part to see whether any rent is there or not, because almost the capsulosynovial area has come anteriorly. So comfortably now you can put your posteriormost stitch with the zone navigator, and you pass the needle through the posterior meniscus or meniscus capsular area and through the meniscus, and then on the undersurface to stabilize the meniscus. Once it is stabilized, you can notice the meniscus is stabilized. Then the graft link was passed through the femoral and tibial tunnel, but it is not tensioned right now. And once it is done, then you tighten the suture of the meniscus one by one from posterior to anterior, and you see the tightening while you are doing the tightening. So first the posteriormost suture, and then you see inside how the capsulomeniscal area is reduced with the help of these sutures. And once you tie all the suture and check the stability of the meniscus, then you tightened or tension the graft on the femoral side and tibial side. And once you do that, then you check the stability again. And clinically also, it is anteroposteriorly stable. and there is pivot shift negative. This is the interposterior stability and negative pivot shift. And this is the post of rehab of this patient. Thank you.